Today, we're super excited to welcome Lauren Barlew to our show. And this is really cool because we're starting a little mini series on answering some questions about what the hell is perimenopause. And we're going to use myself as a guinea pig, and Lauren is willing. I've actually seen her as a client. She is willing to share that information, and let's talk about it because as I am aging past this perfect little perinatal postpartum mental health area of my life I've been in, I've realized that there's another phase that I did not know about. So, Lauren, welcome to the show. You tell us a little bit about you, give everybody an insight, and then we will begin more.
Sure. So thank you for having me. My name is Lauren Barlew. I'm a women's health nurse practitioner. I've been in practice since 2012, so going on about 12 years, I guess.
Yes.
And I have started a practice dedicated to perimenopause and menopause in the Chattanooga area. Just the reason for that, we will dive deeper, I'm sure, but there's not a whole lot of people talking about this, at least in our area. So I'm here to be that sounding board and to help. So that's
perfect. I was going to ask you why, and I really don't know this, even though we've met in other places. Why did you move into menopause? Why did you move into this specialty?
So actually kind of not as directly as I would hope to answer your question. So I actually started this practice as a sexual medicine practice. So like arousal, pain, orgasm, decreased desire. And so these women would come in and they had all those things, but their menopause was not being well taken care of. And so I was like, well, we're just going to be swimming uphill, like swimming in a creek uphill, whatever that's.
I'm with you. Yeah, it's perfect.
Like we're not gonna make progress until we get their hormonal symptoms taken care of. And so then then it just really just organically transitioned into, okay, well, if no one's going to help you with this other stuff, then I'll help you with that. I'm very well versed in hormones. We can totally take care of it. And then it just blossomed into this wild ride that we're on now.
Yeah. Okay. That's right. And I think now I do know that because we've talked about all of that things, but very cool. We can probably talk all day about the ways that you've made it to here with trainings and certifications and things. But since you are the expert, and since our question of the day is, we're going to talk a little bit about menopause, but mostly about perimenopause. My question is, what the hell is perimenopause?
So perimenopause is a time of life that we're transitioning between like our childbearing years to true menopause.
Yeah.
So average age of menopause is 51. And there's different data out there, but I believe, and we believe that perimenopause is 5 to 7 years before menopause, maybe 10. And the thing about that is that it's unfortunately really, it's hard to diagnose because there's not usually like a lab value or some sort of objective thing that we're looking at. So that is why the time frame is variable. So women will come in with different symptoms, and based on their age, which I like to say their birthdays, and the degree of symptoms they're having, and we will do labs. I kind of look at all that whole picture and help kind of determine what we're looking at.
Okay.
But perimenopause is really just the time period of transition. Do you want me to go into comment typical things people are talking about when they come in?
Yeah, take it. Yeah.
So very commonly women will come in with irregular periods, and it might not be that they're so irregular, but they have changed. So whereas they used to have long, heavy periods, now they have short, lighter ones, or vice versa. Like honestly, everything is normal. Or the flow has changed, different things with that.
Yeah.
And then notoriously night sweats, and they often occur before your period. So that time before your period, your progesterone and estrogen levels are going to be really low. And so that is really common to have night sweats during that time.
Okay.
And then insomnia. Is a big one. So often waking up, like the witching hour is 3:00 in the morning. So if you find yourself waking up at 3:00 in the morning, every morning, and you can't get back to sleep, or you can't get back to a restful sleep, that's a big telltale sign.
Okay.
I'll hold for some other symptoms, but
Okay.
we'll start with that.
Okay. So now, I'm just going to go with it because before, just when you said you started your practice with more of like
Mm-hmm.
sexual dysfunction and things like that, and
Mm-hmm.
now women are coming in maybe more because they have these symptoms, like what leads someone to you in the perimenopause transition?
So something that I haven't mentioned yet is honestly what probably leads most menopausal or perimenopausal women in
Yeah.
is mood changes.
Yeah.
So like anxiety that they have never had before or is out of context for what's maybe going on in their lives,
Yeah.
or irritability. Like I hear a lot about women who are raging and I laugh because I'm not, it's just like you see these sweet little, like not little ladies, like 45-year-old girls, and she's like, I have the worst road rage I've ever had in my entire life. Or maybe even like really sensitive to things,
Yeah.
or feeling more overwhelmed. So like I can't tell you how many people come in, they're like, I cannot stand the sound of my husband chewing. Like it's driving me insane. And so we'll kind of pick up on some of that stuff. And like maybe by itself, like being annoyed by your husband's chewing would not, like that's not a medical problem. We don't want to like over medicalize all this stuff. But if that goes in conjunction with night sweats and
Yeah.
insomnia and anxiety and depression, which are new, like that's something that we need to talk about.
Yeah, yeah. So I mean, no matter what we're looking at, because it's a storyline you're picking up. I mean, I remember even when I came in to see you for the first time, it's not like you said, there's not like one little blood test. Oh, you're in the
Yeah.
perimenopause stage. It's a storyline. So people are coming in. Would you say it has to be within, like, let me go to myself, right? So 38-year-old, at the time I saw you, I was 37. I turned 38 the day after, but 38-year-old, right? And I had realized that recently my libido,
Mm-hmm.
my wake ups in the night, my anxiety, things that I thought were just normal aging things of having a 6-year-old,
Mm-hmm.
sort of happened. It wasn't a switch overnight. I would say it was happening within like 6 to 8 months. Would
Mm-hmm.
go with that, right? Like, does that then send up red flags because it's new?
Yeah.
Okay.
It's new,
Yeah.
and frankly, it's not only new, but it's affecting quality of life. So I
Um,
just really feel strongly that we should not, like, we have a lot of life to live, and we
yeah.
should be living it vibrantly.
Yeah.
And if that means that you're waking up in the middle of the night, like I, personally, if I was waking up in the middle of the night at 3 o'clock or whatever your witching hour is, like
Yeah.
I would be I would be angry. I would want some
Yeah.
help. So yeah, so it's like looking at also the impact of how it's or the impact on
Yeah.
quality of life. So if your nighttime awakenings are really affecting your daytime stamina, then
Yeah.
we're gonna look into it. Sometimes even like for you, for example, like a younger woman, I have no
Thank
idea
you,
when
by
you're
the way.
going to I have no idea when you're going to go through menopause. So
Sure.
if you were like an earlier, like say you're going to go through at 45, then it makes sense for you at 37 to be perimenopausal. So what we
Okay.
have to stop doing is saying, well, you're too young to be going through this.
Right.
We're gaslighting these women saying, oh, well, you're in your 30s, you can't possibly go through it. So going through all the questions, getting the labs, and then frankly, sometimes it's a bit of an experiment. I'm like,
Yeah.
well, look here, I see your symptoms; they do really match up with perimenopause. You are on the younger end. Why don't we try a little bit of progesterone, for example, which is we'll get into more detail, and see if it helps. And if it helps, then I think that we are on the right track.
Yeah.
It's not going to hurt anything. I mean, it's most of the patients that come in here are like, please just give me something just to
Yeah.
try it. Please
Yeah.
don't prescribe me an antidepressant because I don't feel like I'm depressed.
Yeah.
So sometimes it's a little bit of, I mean, I hate to say this, but kind of a little bit of an experiment to just
Sure.
kind of feel it out, and see how people respond.
No, absolutely. And it's funny you bring up antidepressants because I've been researching perimenopause in general and what science
Mm-hmm.
there is out there. And I found a
Mm-hmm.
stat, and I don't know the exact statistic, but that like 39 plus, age 39 plus in women, there's like a huge increase in prescribing of SSRIs, of antidepressants, when really they're finding that perhaps those are more perimenopause, menopause symptoms versus like you have actual depression. And so
Right.
it's like a wrong diagnosis.
Right.
So that's very interesting.
Yeah, and I think that it's let's say 10 years ago, even in practice, like I probably was prescribing, I would say I was definitely prescribing more SSRIs than
Sure.
I am now. And, that's fine. It's just, that's why we need to keep educating
Yeah.
ourselves and keep, like questioning the status quo, because if we can get away with not using
Right.
SSRIs, which I'm not hating on them, they
Mhm.
work great.
Yes.
But if we can kind of, I tell my people, like, treat the elephant in the room, like
Yeah.
people usually like that better than just kind of like putting a band-aid on things.
Yeah. Yeah, absolutely. So, and we're going to get into, we have so many things we could talk about, I know, but let's go with me. Let's continue with it. So
Mm-hmm.
I came in to meet you and this will actually give people insight into what it looks like to spend a first session, or not a
Mm-hmm.
session, a first visit with a specialist. So I come in and obviously I meet with your medical assistant who takes all my information, and
Mm-hmm.
then I fill out a form, which I don't remember. So you can help me. And so you have that checklist, I believe, with you of
I
what
do.
I
Yeah.
completed. Tell us what it consists of, what you want to share, and then what stood out to you for me.
Okay. So on our checklist, I would recommend this honestly for any provider taking care of women in perimenopause, menopause age. And it may not be, you may not get any positive responses, but it sure is a good screening.
Yeah.
So we're looking at the degree of which each of these symptoms is affecting quality of life. So I'll just, there's like 40 questions, so we'll
Okay.
go kind of quickly. But so vasomotor symptoms, which you call like hot flashes, night sweats, sleep symptoms, so difficulty falling asleep, but also difficulty staying asleep. Those are two very different things for me.
Yeah.
Heart palpitations or a sensation of butterflies or panic, which I will often get picked up on as like wake. People will literally be awoken by heart palpitations in the middle of the night.
Right.
I'd like to get back to that
Yeah,
later. I
for
have some
sure.
comments. And then we really get into like fatigue and brain fog.
Yeah.
And then mood takes up about 10 of our questions: depression, anxiety, irritability, crying spells, that kind of thing. And then headaches. And then we get into urinary symptoms. So, like urinary frequency or urgency or incontinence. And then we get into more of the sexual functioning, vaginal dryness, pain with intimacy, lack of desire, um, trouble with orgasm, that kind of thing. And
Yeah.
then finally, the last question is about weight, which is a really commonly checked one.
Sure.
And then joint pain and breast tenderness. So that is like a quick overview
Yeah.
of that review of systems, but we ask everybody those questions.
Okay. And what stood out, and I don't remember what I put. I mean, I just went through them in my head, but
Yeah.
what stood out? So you get that form, you come in to see me. What are you
Yeah.
looking at on there?
So I had made a note that you woke up every couple of hours with anxiety and, oh, anxiety related, you had said.
Okay.
So waking up every couple of hours at night, and you thought that that was maybe related to anxiety. You had put in the past 6 months some word mix ups. So, like
Yeah.
saying a word that was not the appropriate word.
Yeah.
And in the past 6 months, increase in urinary frequency.
Yep.
Yeah. And then a lack of desire, which was somewhat bothersome, but it was specifically a decrease after delivering your child, but another dip more recently.
Okay. Okay. And so I think, thank you for reminding me, Almal.
Mm-hmm.
But I think too, so from my perspective, right, when I'm filling that form out, now that I think back to it, like I just associate the changes to, well, this happened after my child was born. This happened after
Mm-hmm.
my child was born. And I remember you saying in our first, what do you call it? A session? What do you Okay, appointment. Gosh, I got to get my own language out of my mind. In our first appointment together, you were like, "Well, how old is your baby?" And I'm like, 6. And you're like, "Oh, one, because I still have a picture of her when she's like 2, but also I think I'm speaking as if I'm like still in the postpartum phase, which maybe is my bias from the clients I treat. So from that list of things that I report to you, right? Do any of them, are you like, what's happening in your specialization mind? Are you saying, ooh, these aren't really about postpartum and beyond, these are now about perimenopause or getting close?
Yeah, I'm thinking about, you know, 6 years postpartum that doesn't, like, don't get me wrong. Like,
Yeah.
obviously, we can have sleep disturbance because we
Mhm.
have a kid that wakes up
Right.
that has their own sleep issues or whatever. So I'm not, that can certainly be child related. But I don't think that it is normal to wake up in the middle of the night several times
Yeah.
because of anxiety.
Sure.
Like,
Sure.
our anxiety should not be, I mean, in my opinion, I don't think that our anxiety should be such that it can awaken us from sleep and then several times a night. The sleep component,
Yeah.
and then change in brain function. And I don't want to, like, again, over medicalize everything, but because we do kind of get blamed for that sometimes.
Yeah.
But like mixing up words, feeling more easily overwhelmed by things that maybe we didn't used to.
Yeah.
You didn't specifically mention this, but I often have people who will say that they used to be they used to be sharp, they used to be able to multitask, and now, like, especially at work, they're just not able to take on so many tasks at a time
Yeah.
and successfully complete them. So a lot of people will say that they have like a lot of balls in the air and they're just kind of like constantly juggling, whereas before they didn't feel quite that overwhelmed by that.
Yeah. Okay. Absolutely.
Um, and then I'm also looking at age and
Sure.
the age at which somebody's mom may have gone through menopause.
Yeah.
Although I commonly get an answer in our generation, everybody says, "Well, my mom had a hysterectomy. I have no idea."
Sure.
So there
Sure.
were obviously a lot of hysterectomies that were going on at that
Sure.
time.
Okay. Because and I don't think I even really remembered my mom. I remember my mom going through it. I don't remember her age, but her age matters why?
Because it does seem to have an impact on, well, we know on when we start our periods, and
Yeah.
then there does seem to be an impact on when we stop having a period. Now, if somebody comes in and they're like, well, my mom went through menopause at 40, like 40 is pretty, I mean, 40 is young.
Yeah.
In these days, we would consider that premature ovarian failure. So I wouldn't, that is a little difficult to tease out. But I do like to know if somebody, like, if their mom went through when she was 57, like,
Right.
then this patient may very well be kind of an outlier, maybe a later bloomer, as I say.
Okay. Okay. No, that's good. So you have you go through my thing and then you ask me follow-up questions. Again, I'm going back to, we're in the first appointment
First
together.
date.
Thank
Mm-hmm.
you. Yes, first date. And we're going through the things and keeping in mind, and all the listeners know this of me, like I'm a mental health professional, right? So even when I say I'm waking up throughout the night with anxiety, it's because I have sort of self-diagnosed that that's due to my own anxiousness about, my daughter or whatever,
Mm-hmm.
which it very well could be. But on the flip side, it could also be, could you still, if I wasn't self-diagnosing, right?
Yeah.
Could it still be, I could just be waking up from heightened anxiety, heightened cortisol, or whatever you want to say,
Mm-hmm. Mm-hmm.
because of
Yeah,
perimenopause?
it's possible. I this has actually been a surprising symptom to me, in that I just feel like I just never pulled it out of people before in my past life of practicing. I don't
Sure.
know, but more often I'm hearing women who will wake up with like that panic or the heart palpitations, like I was saying. So I
Yeah.
can't tell you how many people we've seen that have gone through a complete cardiovascular workup because of these palpitations that are new to them,
Yeah.
and they of course have a negative workup, and
Yeah.
so they're told that it must be anxiety. And I'm like, I get, that makes sense that a cardiologist would say that, and that's fine, nothing against them, but like
Right.
maybe we need to be having our cardiologist looking out for these women.
Yeah.
um, it's not just it's not just me that's taking care of perimenopausal women. So
Right.
anyway, that's kind of a off topic thing, but the waking up with heart palpitations or like panic is not uncommon.
Yeah, and so you had said earlier when we were going through the symptomology list of that screener that you like to give, you said I'm going to come back to heart palpitations. Why? Like, what do we need to know about that?
Because it's just, to me, it's just not a very talked
Yeah,
about symptom.
sure.
And if I just have a lady who's just all of a sudden having heart palpitations like that, wake to the point of waking her up,
Yeah,
that is not normal.
yeah,
And then she goes for the cardiovascular workup, that's negative, and she's told she has anxiety. And I think that with this, and then I'll get to something later too. We're being told, like, not intentionally being told that we're crazy, but we're kind of being told that we're crazy because if you go through all this workup and everybody's telling you that you're normal, you're gonna fall back on, well, man, I'm just losing my mind. Like, I feel all these physical symptoms, but nobody can explain what they are. So I say it to say that, I think we need to, in the medical field, not be so siloed in our specialties and recognize that not everything is anxiety, especially in a 40 or 50-year-old woman.
Yeah, absolutely. And especially in a world where that's the main word we all use now is anxiety. Golly, yeah. That's all I hear, which I treat, right? So it's my specialty. So of course it's all I hear, but that's all, every person. Oh, my anxiety got.
Yeah. Anxiety. Of course it's big and we all have, there's a lot, you can go into it, but there are lots of reasons that people have anxiety. But a lot of the times I'm seeing people who, this is a new thing. Like maybe they had anxiety back in the past, I don't know, because of whatever situation, but this is new and unwarranted, which is, I guess, by definition what anxiety is, but it's like, it's not, it doesn't seem to be triggered by anything, and it's hard to predict.
Yeah. Okay. All right. Which makes sense. So again, back to that original thought, like we're looking for a newer onset of symptoms, of these symptoms. Yeah. Okay. So you meet me. I don't know why I keep repeating myself like I'm in session, but we go through all these things. You see my checklist and you want to draw labs on me. What's happening in your mind? Where do you think I'm going here in this first appointment, not session? Goodness.
So I will often get labs. I sure. 9 times out of 10 do. Some people don't want them for whatever reason, which kind of defeats the conversation sometimes. But
sure,
most of the time we get labs, and that is a hormone panel looking at ovarian function, which is LH, FSH, progesterone, estradiol, and total testosterone. There are sometimes some other labs that we'll throw in there if somebody's like not had a period in a long time or something like that. Sure. And thyroid function, sorry. Yeah. And so that's kind of like the basic evaluation. I do tell my patients that it is pretty, especially the younger that they are, I do try to preface this, that it is really common for perimenopausal labs to be normal. Okay. So I like to tell them that so that they don't feel crazy when they get the labs back.
Yeah.
Really, that's the main reason. It is true, but that is the main reason. And so that when we get the labs back and your estrogen level is normal, testosterone's fine, maybe your progesterone is a little low, but in typical practice, you may not be picked up on that something is wrong. But to me, it's a combination of the symptoms and the new onset of symptoms and somebody's birthday's age. Yeah. And their labs. So looking at the whole picture as opposed to just saying, well, you're a 37-year-old woman, there's no way you could possibly be in perimenopause.
Okay. All right. Which makes complete sense. So you run, you didn't run you ran the over labs on me. Yeah. And what did you find?
So everything looked good, except your progesterone level was just a little low. So what that means is, so progesterone in my world, the way I think of it and explain it to people, is the first hormone to go. So it is usually progesterone that will, have an impact on the first symptoms I was telling you about, the night sweats, the insomnia, some of the mood, like brain fog type things. And so usually we'll start some progesterone if that level is low, and or if we're having symptoms that really sound progesterone related. And so we'll start that at bedtime, which we did for you.
Yeah. Yeah. Because, and the ones, just to reflect, because as I'm learning, like the symptoms that seem progesterone-y, I know that's not a word, but that seem progesterone-y that I reported were what?
The waking up with the anxiety through the night. Okay. And then,
sorry.
So some brain fog I kind of associate with progesterone. To be honest, when we get really farther, not really farther in, but further into this, we'll start to see more significant mood changes. And those tend to me to be more estrogen related, or like a heightened degree. You didn't report any night sweats or hot flashes. So like a heightened degree or onset of those. So it's not like and I think the thing that makes this complicated is not just one hormone or another causing things, but
Sure.
I just know through the natural transition that progesterone is naturally going to go first.
Yeah.
And so we just kind of, we'll start with that. And then based on how the response is, then either make adjustments to the dose of that, or based on the labs, add some estrogen, which can be helpful, but we wouldn't want to do that if somebody still has like robust levels of estrogen, but more if they're like on the lower end.
Okay.
Then the estrogen can help with symptoms that are not well taken care of with the progesterone, or with symptoms that become newer as we go through this journey.
Okay. So since I met you, and just to explain to people, we're recording this in September. I saw you in July.
Mm-hmm.
Since I've met you, whether or not they're newly onset or I'm just more aware,
Mm-hmm.
I'm realizing with reports from my partner as well that like the weekish before my period is the mood is completely wild, which is not my norm, right? I've had a period for a long time. Obviously, there's some mood changes before a period, you
Mm-hmm.
know, for most people, but it has not been the norm for me until recently, where everyone, I could like probably punch everyone. I don't, but I feel like I could, and they're not doing anything. And then night sweats. And so I've realized all of a sudden that about 3 a.m., which is funny that you say that, I'm not drenched or anything. I'm just like, it's like as if I had a tiny fever that broke, and I'm just
Yeah.
like, ugh. And
Yeah.
so those are two that I've noticed since I've seen you.
Mm-hmm.
And that being said, would it still be the same? So progesterone at night, we see if that improves, we come back, and what?
So then we're just kind of, I go back through the list and
Yeah.
just kind of, a lot of times people have forgotten their answers. And so I'll be like, hey, when you were here, you told me that you're waking up with anxiety several times a night. So I'll go back through those and get an idea of the responses.
Okay.
And then I just kind of, make sure that I refresh my memory on the lab results.
Yeah.
So if someone's telling me that they are now having some night sweats, I'm just going back to your labs
Yeah,
here.
please.
Then I'll just kind of look at estrogen levels. Your estrogen level at that time was 122.
Okay.
And we have to keep in mind that, our hormone levels are going to vary throughout our cycle.
Sure.
So I'm just kind of looking at it more as a big picture than just one specific lab reading. So it may be that we actually repeat the labs, a follow up. Based on these labs, you were ovulating, and that is consistent with your ovarian function and your estrogen level at the time.
Okay.
So it would be helpful to get labs in a different phase of your cycle. So I can see like that few days before your period, repeat labs then, and see how low your estrogen level is getting. Because if you're dipping way further than what you should be, then sometimes supporting with estrogen during that time can be helpful. For you, just based on this lab, you probably don't need estrogen all the time, but it might be. I treat a lot of people with PMS and PMDD, premenstrual dysphoric disorder, and giving them a little bit of estrogen right before their period can be extraordinarily helpful.
Okay.
So it's just kind of like, it's not usually that we get it right 100% right every single time, but just, gathering the data, figuring out what helped, what didn't help, where we stand now will just guide what we do next.
Yeah. Just like you said, it's an investigation, or just a journey to see. So I have a random question that pops. So is this how you're going about this? And even like repeat labs, and maybe I have to come in, on a specific date, a couple days before my period. Is this different than the medicine you knew that you would have done 10, 20 years ago?
Yeah, it's a lot different.
Yeah.
So the old answer for perimenopause was putting people on birth control pills, because of that like irregularity of the menstrual cycle. It's getting heavy, it's getting light, whatever. And so I think that a misconception in the like OBGYN world is if we give birth control pills, then we're giving hormones. And so that should help because this is a hormonal problem. So let's give her hormones. But the problem is we're giving hormones that are not similar at all to what our ovaries are producing. They're completely suppressing ovulation and like making our levels like super low as opposed to supporting them. And so we know that giving people like perimenopausal hormone replacement is actually safer than using birth control pills because we're trying to get away from oral estrogens.
Okay. Okay.
We like using micronized progesterone and maybe like a little low dose estrogen patch or a gel or something like that doesn't transfer through the liver the same way as if we give you birth control pills, which has a increased like blood clotting risk.
Yeah.
It lowers cholesterol. Sorry, it raises cholesterol, lowers testosterone. Whereas we can actually get benefits from hormone replacement. We don't have to worry about blood clotting risk. We don't have to worry about lowering somebody's testosterone, et cetera, et cetera. So, and just frankly, it just works better.
Yeah.
So that is different than
Yeah.
how I used to do. I admit I gave a lot of people birth control pills.
Sure.
But I would say that many people, especially like in their early 40s, mid 40s, they're so done having a conversation about birth control pills. While we do need to protect them, they do
Sure.
not want to be put on birth control pills because they've had negative side effects before or whatever. So,
Yeah.
yeah, I would say that in the past few years, my practice has shifted tremendously with this.
Yeah. Which is all the more reason to continue, right? To learn
Yeah.
and grow, just like you said, and advocate. But I'm glad you bring up birth control because that was going to be one of my questions. So, in my ignorance to it all and my fear is every birth control I've ever been on, I do have negative side effects. I'm crazy. Whatever
Great.
crazy is, and I just feel crazy. It actually became a joke with my OB and I, like maybe crazy is just my baseline because it
Yeah.
always anything we try. But
Yeah.
that being said, so then I have a fear, right? I have an internal fear to start any kind of hormone therapy, progesterone, any of it. So if I'm hearing you correctly, I don't necessarily, it's not the same.
No, it's not the same.
Yeah.
No.
Okay.
So I have a lot of people who have reservations about that as well. So
Yeah.
the birth control pills have synthetic estrogen and synthetic progesterone in them, and again are suppressing all of our hormones. So if I check labs on somebody who is on birth control, which I would never do because of useless information,
Sure.
then your estrogen, progesterone, testosterone, ovarian function are all going to be like nothing. They're going to look like menopause. So when people come in and they say that they feel crazy, well, I mean, you might feel crazy because we basically put you, I'm overstating this,
Sure.
don't get me wrong, but we've suppressed all of your hormones.
Yeah.
So it makes
Yeah.
sense to me as a menopause person. Like if we've suppressed everything, then you are going to feel kind of weird. Not
Yeah.
everybody responds like that to birth control,
Sure.
but it
No.
isn't uncommon that I have people who are hesitant because they don't want to go like hesitant to do any hormones because they associate hormones with birth control.
Absolutely. Absolutely. Which this was totally worth it because that just took care of that reservation as you called it, fear
Yeah,
as I call it, but
yeah,
absolutely.
yeah.
Okay. So that being said, and I'll be honest with you, I haven't started progesterone 100 because I wanted to begin this because I was like, in my mind, I'm like, I don't want to go back on birth control, which is such an
Mhm.
ignorant statement, right? But I know there's, one, I'm just realizing there's so much more conversation about like, what do I do? Do I have to feel this way forever out
Mhm.
there with not a ton of answers? So for those listeners, like, I just wanted to get more info. Those who are more, what we call functional medicine, more functional based, like, do you ever recommend that for them? Do you believe, I don't want to say, do you believe that's a tough statement, but are there other ways, do you think, to handle perimenopause?
There are
Um,
some supplements. So I will admit I am not very crunchy in my practice.
yes.
I'll just really state my bias.
Yeah.
I feel that life can be quite better lived through chemistry. And when I say that, I mean, if we are using hormones that are the most identical to what our ovaries are producing, then I don't see the big deal for
Sure.
most people, right?
Sure.
So when I say the most identical to what our ovaries are producing, I know that's going to put people's ears peaked up to like bioidentical hormones.
Sure.
That could be an entire podcast.
I'm sure there's
I'm
one
gonna
out
lie.
there.
uh, so there is a huge push in the menopause world and in the sexual medicine world to stop calling compounded bioidentical hormones bioidentical, um, because what we have that are commercially available, micronized progesterone and the patch that I referred to, or gel or whatever, is much more chemically consistent with what our ovaries are producing.
Okay.
And so we're trying, like, there's a push to get what we do commercially available to be called bioidentical or body identical. It's very confusing for patients. I will
Sure.
just say that I am 99% in the camp of using commercially available estradiol and micronized progesterone, both of which I've lost track of what your question was, to be really honest. I got on a rant.
No, go for it.
but 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 using these, there's a lot of question about safety with hormones.
Sure.
I have a lot of data on safety with hormone replacement that we have data on. So the commercially available, we have no data on compounded bioidentical hormones. So if I have somebody who is nervous about hormone therapy, then it doesn't make sense to me why we would go towards something that we have no data on.
Okay.
You know what I mean? So like
Yeah.
if I have somebody who's really nervous about breast cancer, for example, that's like the elephant in the room always,
Yeah.
then why would we go on a hormone that we have no support
Yeah.
from
Yeah.
a science standpoint? I remember what you asked me. You said for the more crunchy people.
Yeah.
So I do have some people who will opt to do like progesterone supplements or something like that.
Okay.
That they can buy over the counter or through like a GNC or something.
Mm-hmm.
What we know about progesterone is that the molecules of progesterone are very large and there's very little absorption through the skin. So I might have I have one patient that I can think of that we ended up with topical progesterone because she couldn't tolerate the oral as well.
Sure.
But in general, the topical like yam creams and progesterone creams and such are they're frankly just not well studied, but are a lot less likely to have good results. I'm not hating on it. It's worth a try. It's not going to hurt anything, but it just isn't well supported, I guess.
Okay. Okay. Absolutely.
And then there's of course other supplements, like people take ashwagandha or black cohosh or whatever it may be based on their symptoms, and I'm like not against it. If it works for somebody, I'm totally fine with that.
Okay. Okay. But in the end, which makes complete sense, right? If there's reservations, which is a great word to use, if there's reservations and there's research to support this versus not, it would, I get it, that we lean into what we know. Absolutely. Okay. Okay. So that answers no, that's great. Oh, you're answering all my things beautifully. I do have and it'll lead us to a couple more things, but I do have some questions from listeners just that I think are either in perimenopause or some that are approaching. And so we'll come from the approaching thing. But one thing I had even asked you when I met you at the conference we were at, or the women's event, is like, I don't know if I'm in perimenopause or not, but is there anything I could be doing, could be aware of to just better prep myself for this transition in this next stage of life?
Mm-hmm. I think that it's a really basic generic answer, but I think just, taking care of our bodies, eating good, wholesome foods, getting exercise, both aerobic and like strength training, are all going to be helpful for our body's general function. In my opinion, I don't think that there's something that we all need to be doing to be prepping per se, because this is it's inevitable. It's not we're not going to escape it. Hopefully we don't escape it. Right. So I don't have a supplement or something that everybody just has to have. I think the more information that you can gain, maybe that is having a conversation with, for some, maybe with their mom about what their experience was, but for many, probably have conversations with your friends about what kind of symptoms they're having. I think that just kind of helps normalize it so that, again, people don't feel crazy. And that is probably feeling crazy may actually be the most common reason people come in here.
Yeah. Which is so, it's not funny, but it is, it's entertaining. So do you think, it obviously I always look through the mental health lens because that's what I do. But do you think when I teach, patients with anxiety or whatever, we focus on just becoming aware of the mind body connection? Would it be worth for our listeners that maybe aren't in perimenopause to begin to monitor for symptoms? I know sometimes, even I'm guilty of, all of a sudden, I look up, I don't know, somebody says, "Ooh, I heard of bed bugs," and now I'm itching, you almost gain the symptoms. But would it be worth keeping an eye out?
Yeah, I think Yeah, I think it's fine. Like keep an eye out on it. I think that to your point, like we don't want to get so
Right.
hung up that it's causing us anxiety
Yeah.
because
Yeah.
it is inevitable. But I think, just like maybe like a little journal, or most people use like a period app and just like, oh, I am having night sweats like the 3 days before my period, or I'm like a raging monster those days. Um, Even like 2 weeks before my period or a week before my period, that all is very helpful in helping me, for example, know like, are we dealing with, is this more of like a PMS thing, a PMDD thing? Are we looking more, so those all can get kind of complicated with perimenopause. They all
Yeah.
look pretty similar. So that information can be helpful because then when we're talking and I'm like, okay, well, how long have you been a monster before your period? And instead of saying, I don't know, if they said, a year ago, every time I have a period, I'm a monster, then that is helpful
Yeah. Yeah.
information. So I think keeping a log is helpful,
Okay.
keeping up with it, but I don't necessarily want to give this information so that people are acting on every symptom that they
Sure.
have because that's a
Yes.
lot.
Sure, sure, which I understand completely, but yes, absolutely. But yeah, the awareness and the storyline for when it is time to see you.
Mhm.
And on that note, again, still in like, I'm not sure if I have perimenopause stage, I'll journal a little. Like, when is it, and I asked this to you as well at that event, I was like, is it too soon for me to come see you? Like, I maybe have symptoms and I don't know. And you were like, yeah, well, just come in and you almost presented it as like, let's get a baseline.
Yeah,
Maybe I don't have to see you again for a while.
yeah,
Do you
yeah.
feel like that's beneficial for women?
Honestly, yes, I do think it's beneficial. I think I would encourage, and just me personally, I
Yeah.
would prefer that people get a baseline because they're having some symptom.
Okay.
Because if we're just coming in to get a baseline, just to get a
Sure.
baseline, and you're
Sure.
having no symptoms, then, when I tell you that I'm looking at lab symptoms and birthdays,
Sure. You
I
have
mean,
one part
I'm
of the
happy
story.
to check them for you, but
Yeah.
I'm probably not going to act on it, to be honest, because I don't have like a measurable degree of success.
Sure.
So if you have no symptoms, then me giving you progesterone, for example, is going to do nothing for you other than maybe make you feel a little bloated or something. I don't know.
Sure.
But we're not going to like be having a goal for which we're trying to
Yeah.
treat. So I'm fine with a true baseline, but it would be preferable and like more beneficial, I think, if we're having some symptoms.
Makes sense because it goes back to you're getting a story and you're
Mm-hmm.
moving through the storyline, so you need all the
Mm-hmm.
parts. Okay,
Mm-hmm.
no, that answers that
Exactly.
question. So then moving to being in it, and I have many listeners that are in perimenopause
Mm-hmm.
transition, as you called it, and a question I got like 4 different times by people where like, is this brain like, am I inevitably in this brain fog for the forever? Like, is there anything I can help the brain fog? And I again don't know what they're being treated, if they're seeing anyone. What would
Yeah,
be not a quick, but a good answer to that?
yeah. So brain fog, I think, has unfortunately been. I think us in the menopause world are getting a little scrutinized for over medicalizing this, but I do not think we are. So
Okay.
if I have and this may be more relevant in a truly menopausal woman, but that doesn't mean that it isn't the case in
Sure.
perimenopause. But I have the statistics on women exiting the workforce due to menopause, and I would say perimenopause is it's insane. So when we say brain fog, that can look like you're just saying the wrong word, or it can look like
Yeah.
you have a technical job and you cannot put the pieces together. Say you're an electrical engineer. I'm not going to pretend to describe what electrical
Sure.
engineers do, but they literally cannot um, put pieces together. They cannot do their job.
Yeah.
So I have that brain fog is not acceptable to me.
Yeah.
So to me, it just depends on the degree of it, but what we can do about it. So like a truly menopausal woman, that's a whole different
Sure.
question. But for perimenopause, looking at those labs, I can't tell you how many times we find low testosterone levels. And testosterone levels are not going to be dependent on the menstrual cycle. So it does not matter when in your cycle we have that lab drawn. It is what it is.
Okay.
There's a lot of data coming out on testosterone and the benefits to our mental health, physical stamina, um, mental stamina. So truly like correcting that fogginess. So even in perimenopause, maybe we're not using estrogen because we're not that far into it yet, but I am also often using testosterone, which is wildly beneficial.
Which is wild because, again, I'm going to come from my ignorant perspective, right? And like, testosterone is what, men have, and that's put hair on your back, and I don't want any extra hair and all those things.
Mm-hmm.
But it is wild when you drive down the road and there's 15 testosterone clinics where it's, not to say that I know what happens there, but like inject and go, inject and go. And, tons of men come in and out. And here we are talking about it. And I'm like shocked that I would possibly need more testosterone. So it's that's all super interesting. Okay.
Yeah, so women, we have more testosterone in our bodies than estrogen if we're comparing apples to apples, like if we're measuring with the same measurement tools.
Sure.
So it is a female hormone. It is vitally important to those things I said: brain stamina, physical strength. But also, there's a lot of data coming out about bone health, in addition to
Yeah.
bone health benefits from estrogen. So, I mean, from a depression standpoint, it can make a huge change. We just have to, in my world, I like to keep women within a normal physiologic range for a woman. So I
Yeah.
tell people, we're not trying to get you to be like a 20-year-old boy. We're trying to get you, I want you to be you.
Yeah.
So
Yeah.
as long as we keep people within their you, then there is data that says we are not increasing like blood clotting risk, we're not increasing cancer risk, that kind of thing, but we are improving a lot of quality of life factors. I can't tell you how many athletes, and again, we're not making bodybuilders here. I'm talking about like your average
Yeah. Right.
athlete,
Right.
who maybe before, like in her past life, could work out Orange Theory, no problem, all good, and now she works out and she has to recover for 3 days. Um, Having a little testosterone on board can definitely be helpful for that.
Yeah. Okay.
That wouldn't be like the only reason we would do it, but if she
No.
had the brain fog,
Yeah.
maybe low libido, and she was losing her muscle strength, it can be very helpful.
Yeah, absolutely. So, I mean, to circle back, like you don't necessarily have to be in the brain fog, depending on your storyline and what your labs say. Would it be fair though? And I don't know this person's story and who they see and things, but is it? I guess is it a normal? And maybe you can't answer this, but is it normal? Practice from our OBs or whomever to run those labs and look at them the way you do? Is that a loaded question?
It, well, first of all, I see a lot of patients who have had their labs drawn on birth control. And
Okay.
I think that again makes people feel crazy because they get their labs back, they're really low. They're like, what's going on? I must be in menopause and I'm 32 or whatever.
Sure.
And so I really wish I could spread the word. Please stop checking labs on birth control pills.
Okay. Yeah.
But the other thing is I don't want to say in my experience of my patients who have come in, it is really common that women are denied lab work because they are having regular periods. And so they are told that, well, because you're having regular periods, then everything's fine, you're ovulating and all the things. Or they're told that it depends on where they are on their cycle as far as, and that their labs change all the time. So there's no point in checking them. And that is true. They do change all throughout our cycle, except for testosterone. But as long as I know when your last period was, then I check it all. I mean, to be honest, I like to get a random check. I don't really tell people they have to check at a certain time of month. I like to get a random check, and just knowing when their last period was helps me to kind of put those ends together as far as what the hormones look like.
Yeah.
But it also just depends on what we're looking for too.
Sure, sure, absolutely. No matter what, just like you said, we're all going to hopefully all go through it, perimenopause, menopause,
Okay.
and we're over 50% of the population. So we're
Mm-hmm.
the majority. It's
Mm-hmm.
all going to happen. And it's not a death sentence of you have to live in this horrific state of brain fog, moodiness, et cetera, et cetera. And I know menopause is a whole nother level and whole nother thing, but to wrap it back around to me, right?
Uh-huh.
But to wrap it back around, like, our goal then would be I begin the progesterone at night, right? to raise, obviously, to raise that. And when I come back to you, if the progesterone is doing what it should be doing, and I know this is variable for everybody, what would you like? What do you hope to see in 8 weeks when I come back and see you?
I would hope that you say you are sleeping through the night.
Okay.
Or if you are awoken, it is less frequent and you can go back to sleep
Okay.
quickly. Because a lot of the times it's like you're woken up at 3 a.m. and you're rolling around for 2 hours.
Yeah. Yeah.
You know, so like if you can get up and pee and go back to sleep, then I think that that is a success. And then like the mental fogginess, I think should be improved. I will say the brain fog is a little tricky.
Sure.
You know, like a lot of times it is improved with testosterone and progesterone or whatever. Sometimes, you know, to be fair, there are other reasons that people would be foggy.
Yeah.
They've got too
Yeah.
much on their plate or whatever. But for you specifically, the nighttime staying asleep situation, and
Yeah.
then sorry, now I'm going.
No, sorry. I
Lost
jumped back
where
to
we
us,
were.
to me.
I think that there may be some benefit in some dryness,
Yeah.
although
That's what
we
I
think of
wondered.
that as being estrogen dependent as well. Oh, sorry, I lost track. I know what I was going to answer.
No.
You had said that just recently after seeing me, you had noticed whether it was new or because you're more aware of it, the night sweats before your period
Yep.
and the mood. And so since we didn't talk about that in your check sheet, so
Right.
I would say um, I would be really interested to see how that did,
Okay.
that piece.
Okay.
So I think just mostly your symptoms are going to be mood related and some anxiety. For other people that may be a little further down, I would expect their night sweats to go away,
Okay.
so that they're not having to sleep with their AC on at 64 degrees. And
Yeah.
that's the future. Yeah.
Yeah. Yes. Yes. Okay. But that would be optimally. So if I don't come, and this is more of my personal thing, but if I come back and I don't see a change, what do
Uh,
you think? And I know that this is in the future and things could change, but like, what do you think you would do?
so sometimes people can be sensitive to different medications. I do use the micronized progesterone to start with, and most people tolerate it great. Some people don't tolerate it as
Yeah.
well, and maybe they feel I had kind of quietly mentioned some bloating or they
Yep.
feel tired during the day. There are different types of progesterone that we can use, but I would actually probably back down. So the 100 milligram progesterone is the lowest dose of that type of progesterone that we have at the regular pharmacy.
Okay.
I can get compounded lower dose of that.
Okay.
And so we may just back up a little bit. If you're having some, like some people will say that they feel like a little hungover or they feel, this is like not typical.
Sure.
It's not
Yeah. Yeah. A
people.
little. Yeah.
Where sometimes we'll start low and work our way up. It just kind of depends on like where the pendulum swings. But I would probably still focus on the progesterone.
Okay.
And then your testosterone level, let me bring that up again. I remember telling you that it was normal. Sometimes I'll go back at that and be like, well, could we like just, I hate the word optimize. Could we tweak that a little bit,
Sure.
like ever so gently? Would that help? So your testosterone level was 27. So in menopause world, our normal is 15 to 75.
Okay.
And so 27 is, you know, kind of mid range. You
Sure.
could maybe use a little bit of boost if you're still having trouble or if someone was having trouble with fogginess or whatever.
Okay.
So maybe like a lower dose of testosterone than what I would typically use.
Okay. But no,
So
go
a few
on.
tweaks.
Yeah, no matter what, like, and I feel like it's, I'm relating it again to mental health, but it's the same. Like, we're taking symptomology. There's no, like, in mental health, I can't draw blood to say, yep, you have bipolar 2. Like, it's just this storyline we put together, and then we treat the symptoms and move through the process, however it is. And it sounds the same with where it's at. Okay.
Yeah.
So now I know my treatment plan, and I
Your
appreciate it.
plan.
Yes, yes. And
Yeah.
I will say I have two more things, but one
Sure.
of the biggest questions, and of course, I know that you and I have talked about this and you talk about it in many of your interviews, is like, and it was, quote, why the hell is no one talking about it? And why the hell doesn't my doctor know? And
Yeah.
so from your perspective, like, I mean, why is it just now becoming a thing? Why is there no research on it?
Well, I think truthfully it's becoming a thing because of social media.
Okay.
You know, it's always been a thing.
Sure.
Perimenopause has always been there. I think social media, I think that women are increasingly in roles that they cannot tolerate the symptoms.
Yeah.
So if you are, I mean, I'm not saying like obviously like stay at home mom or professional or whatever,
Yeah.
like if you're, whatever your role is, it is, we have so much on our plates. And it's, if you have, if you're not sleeping at night, like you cannot perform whichever role that is. So I think that women are just being more assertive, and recognizing that there can be better out there. And so they're talking to their friends, and then they get it reinforced on social media, and they're like, oh, maybe I can do something about this. I don't have to just push through.
Yeah.
So I think that's why we're talking about it more. I think, or I don't think, I know that unfortunately menopause is not taught in medical school. I think the average duration of like a lecture on this is like 8 hours through the entire medical school residency. So they're not talking about menopause. So they're definitely not talking about perimenopause. So again, women just kind of continue to get reinforced that we're crazy. Like everything's fine. You're still having regular periods. There can't be anything wrong with you. A lot of times I will have that little sheet that people fill out, and they'll say like towards the end, they'll be like, something has to be wrong with me. I'm like, I'll flip the sheet around to him and be like, you literally feel like ticked all the boxes on here. I have detailed every little thing. Obviously there's something wrong with you. Like, let's deal with it. At least, I mean, at the minimum we can try. It's not going to hurt anything. Again, it's definitely not going to hurt anything to get some labs. It's not going to hurt anything to do a little tweaking.
Yeah. Yeah. Which I think goes back to the whole idea of like, not go back to, because I don't know that we've discussed it, but we're just women's health and women's mentality has historically been like, suck it up, buttercup, do it all, do it perfectly and do it quietly. And so you're right. This voice is bringing attention to like, wow, we've been missed. And we're like 52% of the population. So it's crazy. Anyways, we can go on for all.
I know. And there's
ahead.
so much that like is on our backs from a mental load. I don't have to tell you this, but like we're moms, we're wives, we're professionals, we're whatever. We manage the family, we manage the household. Really, in many cases, regardless of what the role is. So I think we're just tired of being tired, maybe.
We're tired of being tired and tired of being told we're crazy. And then we begin, my big thing is the brain believes what we tell it to believe. And like, so not only are we told we're crazy, we believe we're crazy because that's all we got out there. So yeah.
Well, it keeps being reinforced. Yeah.
That's it. Absolutely. Absolutely. Yeah. So we can get on a soapbox about that. But my last thing on that is and I do have mental health professionals that listen, and I for my own thing, but as I'm aging in my practice, I feel like clients are aging too, right? I'm getting more people my own age and older. Like, do you have you had clients that come through, or patients of your own that come through where maybe they are treated for mental health and a lot of these symptoms were just pushed as mental health symptoms, like just this is anxiety because here's an antidepressant, things like that. Like, is there any, I don't know what I'm trying to ask, but like, what part of my interview with clients and me watching clients would you, from your perspective, you like me to be like, hey, perhaps it's time to go visit Lauren, or perhaps it's, that.
I just like my lens is generally in our 40s.
Sure.
Anybody in their 40s, I'm considering perimenopause. So
okay.
I think that it's fair for other professionals to consider that as well, whether you are cardiology, like we said, or mental health provider or primary care.
Yeah.
I think we need to be kind of ruling out that perimenopause could be the problem instead of it being the last thing that we consider.
Yeah.
Because it is inevitable. Why would we, why are we not considering it as a possible cause? That's the super frustrating thing to me.
Yeah, that's.
So I would just say a woman who presents in her 40s with new onset of anxiety, depression, any really mood stuff,
let's rule it out.
You don't have to go through my whole list, but I would consider it.
Okay. Is that scale that you have, or that assessment, is that your own?
I adopted it from the Menopause Society. I'm a Menopause Society practitioner, so I adopted it through them and then kind of tweaked it for us.
No, that's beautiful. Yeah. No, we would love to see it just to share and know. And I think bottom line is like, the more we talk about it, right? Which I know you have been running crazy talking about this stuff. I see on social media all the time and at these events, but that's the best way to get the word out. Is there anything, this is the last thing, anything we didn't cover that you think we have to know about this first part of perimenopause? Anything else?
I think that men need more education on this.
There you go.
We get asked a lot, like, about men's classes and that kind of thing. And I we put out like a taste. I'm losing my word. Like a survey to see what kind of class a man would come to learn about this. Like, would it be better at a happy hour, or would it be better in a classroom? Like, I don't think they're going to come to my office. So, just spreading the word to men to, like, this is real. Your wife is not crazy. There are things that we can do to help her through this. I don't have the bandwidth for it right this second. I want to spread the word to men. And so if anybody has any ideas how to get that done, I'm open to thinking about that. But I think that it takes two to tango. It's not just one-sided. Everybody needs to know.
Absolutely. Because if men knew more, if men were listening or given the chance to hear, let's say it that way, as much as, I feel like even women are more and more, what do you think would change? What do you see?
I think less like accusation about the crazy and the changes, like whether it be like PMS symptoms or whatever. And maybe more tolerance, or just more understanding. So maybe if he knew that the week before your period you were a monster, then maybe he backs off, or like doesn't initiate sex. That would be a good one. Or
all the tips and tricks. Absolutely, though.
It's like being in tune.
Which is, it could only, right, especially if they're in a relationship, it could only benefit the relationship for the communication factor. Okay, I'm gonna we might be back with the men's episode, but they can even listen to this one and gain. I mean, we're all,
I know, so I agree.
I will push that. Okay,
I agree.
All right. Yes. That's beautiful. Hey, listen, I am so thankful to take your time and have you on today. People are in the Chattanooga area. Do you do telehealth, or is it mostly you need to be present?
Do telehealth. We do. So in the state of Tennessee and Georgia, we can do telehealth. And happy to do that. If you're in the Chattanooga area, I personally prefer in person. I think it's a lot more personal. But we can do telehealth at your convenience as well.
Okay. So we will have all of your info in our description. The Lotus Center for Women, it's growing fast. I know that. You keep adding people. I see it. And if anything, if you're out of those states, you just need to follow your social media. I've learned the questions I have to ask you more on are just from your social media that I follow. So it's all beautiful. I thank you so much for being on today.
Thank you. I appreciate you.
Absolutely.
Yeah.